Hello, my name is Amy Higgins, and the topic of this presentation is postpartum depression screening in the neonatal intensive care unit. I chose this topic because as a NICU nurse, I have witnessed parents struggle with the stress of having their infant admitted to the NICU and the emotional toll it takes on them. The worldwide rate of postpartum depression is about 10 to 15%. However, in parents whose infant is admitted to the NICU, this rate rises to about 40%. Postpartum depression, abbreviated PPD, can cause decreased rates of breastfeeding. Oxytocin is released during skin-to-skin contact during the first hour of life. This release of oxytocin can decrease postpartum depression symptoms and facilitate maternal-infant bonding. An infant born prematurely may not be able to stay skin-to-skin with the mother for the first hour for this important bonding time. Additionally, infants who are born prematurely are at a higher risk for breastfeeding ending sooner than their full-term counterparts. This decreases the amount of oxytocin released and can contribute to postpartum depression. Another effect of postpartum depression is increased risk of suicidal thoughts. In one study, 33% of mothers whose infants were hospitalized experienced suicidal thoughts, compared to 14% of mothers in the general population. NICU graduates of mothers experiencing postpartum depression have an increased likelihood of emergency department visits within the first 3 months after discharge from the NICU. They are also at higher risk of family and financial stress than mothers of healthy term infants. These statistics underscore how addressing postpartum depression in the NICU setting can affect the health of the mother and the child. The American Academy of Pediatrics recommends screening of mothers at the 1, 2, 4, and 6-month well child visits. However, these visits may be missed while the infant is still hospitalized. This is why screening while the infant is admitted becomes so important. This image depicts the multiple risk factors and protective factors involved in postpartum depression, starting from before conception to child development. The effects on the child and mother last long after pregnancy. Preterm birth and NICU admission is listed as a risk factor in the birth and postpartum periods, respectively. If these risk factors are combined with any other risk factors, the risk can become incredibly high. The PICO question I developed for this clinical problem is, does screening mothers for postpartum depression whose infants are admitted to NICU for at least 2 weeks increase the identification and subsequent treatment of postpartum depression compared to not screening mothers in the NICU? I chose the time frame of 2 weeks because postpartum depression symptoms usually begin 1 to 3 weeks postpartum, according to the American College of Obstetricians and Gynecologists. I chose an evidence-based practice approach to address this clinical problem. I chose this approach because it is a problem-based approach that incorporates the best available evidence along with current practice and considers the values, beliefs, and desires of the patients and their family. I felt that with a topic as sensitive as postpartum depression, it is important to incorporate the values, beliefs, and desires of the patient and family. I would utilize the Johns Hopkins Nursing Evidence-Based Practice Model to design this intervention because I feel it fits the problem, as well as includes the components I feel are the most important to include, as well as includes an interdisciplinary team. This model has 3 core elements: practice question, evidence, and translation. During the practice question phase, an interprofessional team is recruited, a practice question is developed and refined, the scope of the question is defined, stakeholders and project leadership are identified, and team meetings are scheduled. An interprofessional team is very important for this topic because in the case of a positive screening, referrals will need to be made to specialties outside the NICU. Having these resources involved in the project ensures a smooth process when the need is identified. If a mother needs help, it is important that everyone is on the same page and the process can quickly identify the most appropriate resources and next steps. The evidence element includes the search for relevant evidence, appraisal and summarizing evidence, and evaluating its strength and quality. The translation phase begins with determining the fit, feasibility, and appropriateness for the translation pathway. Following this analysis, an action plan is created, including obtaining support and resources to implement the action plan. Outcomes are evaluated and reported to stakeholders, the next steps are determined, and the findings are disseminated. The result of this process is best practice, which can then lead to practice improvements. This is a cycle, however, that allows for continued analysis and improvement of the project. The evidence-based practice change I would want to implement is routine screening using the Edinburgh Postpartum Depression Scale of all mothers, starting at 2 weeks postpartum. This screening would then be repeated at the 1, 2, and 4-month marks. Positive screens would then be referred to the appropriate resources. This image shows the Edinburgh Postpartum Depression Scale. It is a simple 10-question validated screening tool that only takes a few minutes to complete. It is available in 60 languages and is considered the gold standard tool for screening for postpartum depression. Any score of greater than or equal to 10, or an answer other than never to the last question that addresses thoughts of harming oneself, is considered a positive screening. The anticipated outcomes are an increased screening and identification of postpartum depression in NICU mothers. Even if a screening is negative, taking the screening can increase the recognition of symptoms in case they begin in the future. The most important part is the opportunity to make appropriate referrals for the mothers who need them. By using the evidence-based practice approach, more specifically the Johns Hopkins Nursing Evidence-Based Practice Model, I anticipate that the intervention will be grounded in evidence and use the best known evidence at the time. By including an interprofessional team, the intervention will include the best of each discipline. The part of the model that shows reassessment of the intervention suggests that there is always room for improvement, which is an important aspect of any process. In 3 different studies, the percentage of mothers whose postpartum depression screenings were positive were very similar. None of these settings were using postpartum depression screenings in the NICU prior to the study. The referral process in this situation is a bit different from a normal referral. By the time the first screening is completed at 2 weeks postpartum, most mothers are no longer patients, so how are they effectively connected to resources? Several studies have addressed this hurdle. One algorithm is shown here, with the steps to be taken depending on the EPDS score. If the answer to question 10 about harming oneself was positive, the medical team is immediately notified, along with the unit social worker, and urgent follow-up is begun. The medical team and social worker assess the mother to determine if she is a threat to herself or others. If it is determined that she is in imminent danger, the medical team and social worker facilitate a psychiatric evaluation through the emergency department. I could see this being implemented in the NICU where I work, because there is always an OB team, as well as a NICU provider in-house. We have our own case manager available during the day. However, on nights and weekends, there's always a case manager on call who can assist. By involving these parties as part of the interprofessional team, they can be prepared for these situations. In this algorithm, if suicidal ideation is not part of the screening results, the mother is given a packet detailing the screening results and resources she can access. The mother is also encouraged to contact her established primary care provider, OB/GYN, or mental health provider with these screening results for evaluation and treatment. A systematic review found varying approaches to positive postpartum depression screens. All studies in this review referred mothers with positive screens to hospital and community services and provided them with brochures that detailed information about mental health providers and community resources. One study referred them to inpatient psychologists. Another escorted mothers with severe depression scores to the emergency department for immediate intervention. Screening results were also faxed to the mother's primary care provider in one study. Another study had the resource of a licensed professional clinical counselor that covered maternity services and was available for referral for mothers at high risk for postpartum depression. The results of screenings were documented in the infant's chart due to the fact that the mother was no longer a patient. If a screening was positive, a consult was placed in the electronic health record for the licensed professional clinical counselor, who met with the mother in a private room in the NICU within 3 days. Documentation of these meetings was made in the infant's chart. When the infant was nearing discharge, the counselor provided appropriate referrals to continue to receive medical health care outside the hospital. My thoughts on this are that if a mother needs immediate help, I would escort her to our OB triage area, which would make her a patient. This would allow for the appropriate referrals and consults to be made with appropriate documentation. If she refuses, I would notify the OB team and make a blocked note in the infant's chart, which is common practice when there are concerns about the safety of the mother or infant. A licensed professional clinical counselor in the NICU sounds like a luxury. However, identifying a member of the psychiatric team who is willing to round with mothers in the NICU on a regular basis and be a resource for consults and referrals sounds like a reasonable ask. Another hurdle to overcome is barriers to care. Poverty can affect families on many levels. Lack of paid leave, transportation if the NICU is far from home, medical costs, and childcare for other children can all be financial strains on a family. Lower socioeconomic status is also linked to lower usage of mental health interventions. Mothers of color and those who live in rural locations are less likely to receive treatment for postpartum depression. Trust is an important component of all mental health care. If there is not trust between the patient and healthcare team members, a person is less likely to disclose their symptoms due to fear and/or stigma surrounding the symptoms. Culture can also be an important component, as not all cultures view the symptoms in the same way. It is important to deliver care in the person's own language while keeping in mind cultural differences in responses. Some cultural communities have a distrust of medical providers and government agencies and may not be willing to accept help from them. While researching this subject, I have identified some opportunities for further research. One of them is screening of partners. I found some research about screening partners, however, it was minimal. I chose to focus on mothers for this project. However, I would be interested to see the similarities and differences in how men and women experience postpartum depression. Another opportunity is education for bedside nurses on therapeutic communication and trauma-informed care, specifically for the NICU setting. While both are usually covered in nursing school and maybe in a nursing orientation, it should be a continuous process of education. Decreasing stigma around postpartum depression is important to increase the rates of screening and the number of people who accept mental health care. The more this topic is talked about in a non-judgmental manner, the less stigma there will be. These are my resources, and thank you so much for listening to my presentation.